Thyroid cancer. 1. Introduction. Thyroid cancer is the most common malignancy of the endocrine system. It originates in the thyroid gland, a butterfly-shaped organ located in the anterior neck responsible for producing thyroid hormones, T3, T4, that regulate metabolism, growth, and development. Although thyroid cancer is relatively rare compared to other malignancies, its incidence has been steadily increasing worldwide, partly due to the widespread use of imaging techniques that detect small thyroid nodules. The majority of thyroid cancers are well differentiated and have an excellent prognosis, but aggressive forms exist that require urgent management. Definition. Thyroid cancer is a malignant tumor of thyroid follicular or parafollicular cells, characterized by uncontrolled growth, local invasion, and the potential for distant metastasis. It is classified into several histological types with variable biological behavior and prognosis. 3. Etymology. The term thyroid is derived from the Greek word thyrios, meaning shield, referring to the gland's shield-like shape. Cancer originates from the Latin cancer, meaning crab, describing how the tumor spreads with claw-like projections. Number 4. Epidemiology. Thyroid cancer represents 1 to 2% of all cancers globally. Incidence rising, especially in developed countries, partly due to early detection. Gender distribution. More common in women, 3-1. Age typically presents between 30-50 years, though can occur at any age. Survival. Differentiated thyroid cancers, papillary, follicular, have a 5-year survival 95%, while anaplastic carcinoma has survival of only a few months. 5. Types of thyroid cancer. 1. Papillary carcinoma, 80 to 85%, slow growing, well differentiated, often spreads to cervical lymph nodes, excellent prognosis. 2. Follicular carcinoma, 10 to 15%, more aggressive than papillary, spreads hematogenously to bone, lungs, liver. Good prognosis if treated early. 3. Medullary carcinoma, 3 to 5%, arises from parafollicular C cells that secrete calcitonin, associated with MEN 2, multiple endocrine neoplasia syndromes. Moderately aggressive. 4. Anaplastic carcinoma, 2%, extremely aggressive, rapidly growing mass. Poor prognosis, survival usually 6 months. 5. Other rare forms, thyroid lymphoma, sarcoma, and metastasis from other cancers. Cause 6. Causes. Exact cause remains multifactorial and unclear, but involves genetic and environmental factors. Genetic mutations, RET-PTC rearrangements, papillary carcinoma, BRAF mutation, papillary carcinoma, RAS mutation, follicular carcinoma, RET proto-oncogene mutation, medullary carcinoma, radiation exposure, especially in childhood, family history, inherited syndromes, MEN 2, familial medullary thyroid cancer. Number 7. Risk factors. Female sex. Age 20 or 60, history of childhood head neck radiation exposure. Family history of thyroid cancer or MEN 2. Iodine deficiency in follicular carcinoma. Previous thyroid disorders, e.g. multinodular goiter. Complications. Local complications, airway obstruction, tracheal compression, hoarseness from recurrent laryngeal nerve damage, hypoparathyroidism after surgery. Systemic complications, lymph node metastasis, papillary, hematogenous metastasis to lung, bone, liver, follicular, aggressive local invasion, anaplastic. 9. Pathophysiology. Genetic mutations, dysregulation of signaling pathways, MEK, PI3K-AKT. Normal thyroid follicular or parafollicular cells undergo malignant transformation. Tumor cells proliferate uncontrollably, invade thyroid capsule and nearby structures. Spread occurs, papillary via lymphatic system, follicular via bloodstream, medullary via both lymphatic and hematogenous routes. Distant metastases compromise function of vital organs, lungs, bones, liver. 10. Signs and symptoms. Most common, painless neck lump or swelling, hoarseness or persistent voice changes, difficulty swallowing, dysphagia, breathing difficulty or stridor, airway compression, enlarged cervical lymph nodes, sometimes asymptomatic, detected incidentally on imaging. 11. Medical diagnosis, history and physical examination, thyroid ultrasound to detect nodules and guide biopsy. Fine needle aspiration biopsy, FNA, gold standard for diagnosis. Blood tests, TSH, T3, usually normal, calcitonin elevated in medullary carcinoma. Imaging, CT, MRI, PET for staging advanced disease. Radioiodine scan to detect functioning versus non-functioning nodules. Genetic testing, RET mutation screening for medullary carcinoma. 12. Nursing diagnosis. Ineffective airway clearance related to tracheal compression or surgery. Anxiety related to cancer diagnosis and treatment. Risk for impaired verbal communication due to nerve damage. Risk for imbalanced nutrition, less than body requirements due to dysphagia. Deficient knowledge regarding treatment and self-care. Now 13, medical management, surgery, total thyroidectomy or lobectomy, mainstay of treatment. Radioactive iodine, RAI, destroys residual thyroid tissue cancer. External beam radiation therapy for advanced unresectable disease. Chemotherapy, limited use, mainly in anaplastic. Targeted therapy, tyrosine kinase inhibitors, sorafenib, lenvatinib for advanced cases. Thyroid hormone replacement therapy, lifelong levothyroxine to suppress TSH and maintain metabolism. And 14, nursing management, preoperative care. Provide education about surgery and outcomes. Reduce anxiety through counseling. Assess airway, voice, and nutrition. Postoperative care. Monitor airway, bleeding, and vital signs. Watch for hypocalcemia, tetany, numbness. Pain management and wound care. Assess voice for recurrent laryngeal nerve injury. Long-term care. Educate about lifelong hormone replacement. Teach signs of recurrence and complications. Encourage follow-up visits and self-care strategies. Have 15. Treatment options. 1. Surgery, thyroidectomy/lobectomy. 2. Radioactive iodine ablation, I-131. 3. Thyroid hormone suppression therapy. 4. External beam radiotherapy. 5. Targeted therapy, TKIs. 6. Chemotherapy aggressive cases. 16. Psychosocial interventions. 5. Psychological counseling helps manage fear, depression, and anxiety. 2. Support groups provide peer encouragement and shared experiences. 3. Body image support, scar management, cosmetic guidance, self-esteem building. 4. Patient and family education about treatment, side effects, and long-term care. 5. Stress management strategies, relaxation techniques, yoga, mindfulness. Sum 17. Prevention. Avoid unnecessary radiation exposure, especially in childhood. Ensure adequate dietary iodine intake. Genetic counseling and RET mutation screening for high-risk families. Early evaluation of thyroid nodules and neck lumps. Regular screening for those with family history of thyroid cancer. 18. Conclusion. Thyroid cancer is the most common endocrine malignancy, with a wide spectrum ranging from indolent papillary carcinoma to highly aggressive anaplastic carcinoma. Early diagnosis and appropriate treatment result in excellent outcomes for most patients. A multidisciplinary approach involving surgery, radioactive iodine, hormone suppression, nursing care, and psychosocial support is crucial to optimize survival and quality of life. Prevention strategies, patient education, and regular follow-up further reduce morbidity and mortality associated with thyroid cancer. Thank you. Have a nice day.